Hello, everybody. A very warm welcome to you all. I'm Alan Bookbinder. I'm the new master of Downing College, and so this is my first UN lecture. I'd like to especially welcome Professor Gabriel Un and Dr. Chong Hao Un, whose father's gift makes these lectures possible, and to whom we are immensely grateful. I'd like to invite Dr. Un just to say a few words before we get on to the lecture itself.
Thank you, Alan. Just wanted to say a few words. The UN funds was established about 50 years ago in 1975 to support undergraduate. It started off with undergraduate, but now Downing, over the years, has become is huge in terms of there are about 30 undergraduates and clinical students a year. This lecture actually is a tripartite involvement of the medical school and Downing and the family. And I wanted to thank Patrick Maxwell for having sourced Mihaela for this talk, and also Downing for this superb and excellent organization of this lecture, great posters, and of course, I would like to thank Mihaela for having honored us with this lecture. I hope that by the end of your lecture, I will have a job as a doctor, and perhaps if the machine has a virus, you'll come and look for a doctor. Thank you very much.
Thank you. So, today's speaker is Professor Mihaela van den Schaar, who, like me, has recently come to Cambridge. She, as the John Humphrey Plummer Professor of Machine Learning, Artificial Intelligence and Medicine, and a faculty fellow at the Alan Turing Institute. Mihaela says that her research interests are on developing cutting-edge machine learning and artificial intelligence theory and methods for medicine and personalized education. Her lecture, as you see, is entitled Medicine 2.0, Transforming Clinical Practice and Discovery Through Machine Learning and Electronic Health Engines. Please, would you welcome to the stage Professor Mihaela van den Schaar.
Thank you so much. Thank you so much for the introduction, and I'm very honored to be able to deliver this UN lecture. And also, I'm delighted to have the opportunity to welcome so many friends and colleagues and tell you a little bit about my research. Before I go on, I'd like to thank my brilliant PhD student, Ahmed Allah, and my collaborator, William Zaim, as well as many clinical collaborators. And I hope that the group of collaborators will grow even further. We are witnessing a revolution in medicine, and this will provide new understandings of diseases, new understandings of the relationships among diseases, as well as new understanding of the effects of interventions. And this will lead to new ways of screening and monitoring, preventing disease, diagnosing and staging disease, treating disease, inclusively, hopefully, looking differently at the way we conduct clinical trials, a better and more effective way of allocating the clinical resources we have, and hopefully new pathways of care. I view as my role and my part in this revolution as the development of cutting-edge machine learning methods, techniques, and systems in the area of artificial intelligence, as well as machine learning and operations research, with the overall goal of understanding the basis of health and disease, supporting clinical decisions through individualized medicine, informing clinical pathways, better allocation of resources, as I mentioned before, as well as informing public health. In a similar way in which the microscope, when it was developed and people learned how to use it, has really led to a new way of thinking. I believe that in a similar way as machine learning techniques are developed, especially machine learning techniques that are developed for the purpose of enabling medicine, they can provide a tool set that could be equally invaluable in the future as a variety of both patients, researchers, and clinicians are engaging with these methods to do new discoveries and get a better understanding of disease. So I view machine learning, like the microscope of the past, as a multi-purpose tool. To understand what's possible and the type of questions we can start to ask, let us start with Anne, which was just diagnosed with colon cancer. And a first thing that comes to mind when looking at Anne, and you see that she's really quite young, is that maybe she has had a hereditary cancer, and there may have been some mutation that may have led to this. But this is not the case. In reality, like Anne, most cancers that are diagnosed are not necessarily hereditary. There are a variety of other factors that can lead to this particular disease. So both Anne as well as her doctor are asking themselves, well, why did she get colon cancer? What are the factors that have contributed to her getting this disease, and how did they interact? So if we would have at our availability a good map of the health trajectory of Anne, all the various morbidities, but also other information, such as her stress level, which has been high for quite a long time because she has a very busy job, and she has been under a lot of stress, which has led to her having also very poor diet. So if one could interrogate such data in an integrated way, maybe we can start to understand what may have led to Anne's getting this disease. Also, another question we may ask is, when was really the onset of this disease? Was it really very recent, or when did she develop this disease? And possibly we'll have a way to understand and exactly mark when this disease has occurred in Anne. And again, this will be useful both because we would understand what factors have interacted and how did they interacted over time to lead to this diagnosis, but also because we can then start to ask and answer questions such as, could we have known to screen people like Anne earlier, thereby leading to an earlier diagnosis? And possibly, if we can do that, can we stage and grade disease in a more accurate and quantitative way? And if we can do that, maybe we can have a more accurate characterization not only of her current stage of disease, but also how this disease evolves over time, and possibly how we can personalize treatment for Anne. And in this way, not only looking at her current disease, but also at her lifestyle and the patterns that have influenced her healthcare so far. So in order to be able to have a tool and a mechanism to solve and answer such questions, what needs to be done? So many things will need to happen, but at least two I would like to talk today about. One of them is we need to have better ways to understand health and disease trajectories. And this will enable us to understand better patient physiology, behaviors, and symptoms, and how do these interact with each other over time. What are the factors that play a role, and what is the interplay between these factors, and what is the long-term and short-term effect of these interactions, and what is the unique characteristics of the patient at hand that may make these factors evolve in different ways? Can we understand better causal pathways and how they interact not only in the moment but over time? How do morbidities not only interact in the moment, but how do they co-evolve over time? Does it matter that one disease preceded another? And how symptoms associated with these diseases exhibit each other? Also, can we refine further phenotypes and ontologies such that we can better understand health and disease stages? And we can do that in a more accurate way And this would enable us to also do better subgroup analysis and understand how to think about disease in a more granular fashion. Last but not least, we would like also to understand treatment effects and be able to answer counterfactual questions about what is the right type of treatment for this particular patient, and what would have happened if this type of treatment was given to a different patient or the current patient, as well as looking at side effects and drug-to-drug interactions. But while this is scientifically very important and will inform us with respect to future patients, for Anne, this is no longer an option. She needs to be currently treated. And we would like to be able to, in addition to having a better understanding of diseases like Anne's, also provide the clinician, but also everybody involved in Anne's healthcare, including herself, provide her with a decision support system that is personalized to Anne, that is holistic, taking into consideration the entire set of morbidities and lifestyle of Anne, and is longitudinal. And we would like, for instance, to be able to do prognosis, to understand how different comorbidities and competing risks may evolve over time, how symptoms may evolve, how complications may occur, and also what is the chance that Anne is going to die in a certain amount of time. We'd also like to be able to learn as well as forecast longitudinal trajectories of disease Anne, of Anne's disease. And if we can do that, this will improve the way we are screening Anne in the future also. How can we monitor her disease and possibly the reoccurrence of disease? And in this way, try to answer questions that are more profound than just screening and monitoring. Try to ask who should be monitored, when should they be monitored, what type of markers we should look at, and possibly with what technology and with what type of accuracy do we need this monitoring to happen. And would the value for this patient be different than for another patient? And hopefully if we do that, people other than Anne are going to be diagnosed earlier, and there will be better plans inclusively determining what treatment to use, but also when to start treating. So how to do all this? Well, one particular solution that I am developing together with my students is called Learning Engines for Health. And the idea is that we are building an integrated ecosystem using machine learning, artificial intelligence, as well as operation research to provide clinical insights for all the stakeholders in the healthcare provision, inclusively the patient, and that can operate at all stages of care, whether it's prevention, screening, diagnosis, or treatment. And learning engines for health are fueled by machine learning at every stage. It is machine learning that turns data into analytics. It is machine learning and operation research that turns analytics into plans, which are then operationalized using machine learning, artificial intelligence, and operations research, and we observe outcomes, which are then evaluated by stakeholders, again using machine learning techniques that are enabling us to compute, for instance, counterfactuals, and that turns it back into data, thereby completing an entire cycle of continuous improvement. So these learning engines for health are providing an individualized, integrated, quantitative, and cost-effective approach to understanding disease better, tracking the patient over time, as well as improving the healthcare pathway of this particular patient, and hopefully doing that at the population level as well. So we have another patient here, Mary, and what we have here is a holistic view of this particular patient with all the different risks that she is at. And what we are able to look is not at risk at only one moment in time, but risk across time, as well as how the different risk factors interact with each other across time for this particular patient. This is an integrated view that can be used at all stages of care and in multiple locations, not only in the hospital or in outpatient clinics, but also by the patient herself at home, such that she can become more involved in her own healthcare. And hence, there are many stakeholders at every stage that need to be involved with such a system. Not only the clinician and nurses, which are usually involved in this, but also we view these learning engines for healthcare as being an important ecosystem that can inform researchers doing clinical research, but also healthcare planners that can better understand how to allocate resources, not only at the populational level, but also at the subgroup or even individual level. And last but not least, patients, who hopefully will become much more engaged with their own healthcare, such that they realize the impact of their own lifestyle and their own way of treating the different ailments that they have, whether taking medications when they should, or adopting a better lifestyle, such that they can see themselves how a particular intervention that they are taking has a beneficial impact on their own health. So again, let us go back to what is possible. So we would like to use such an ecosystem to be able to really understand what is possible. And if you look at Mary again, you see her risks being projected for a variety of different diseases. But as time goes by, different events are happening, and this is going to lead to future prognosis for future events of this type. And as we go even further into the future, this risk will need to be continuously adjusted. So what we would like to understand is a way in which we can both predict for the current patient as well as understand at a deep physiological level how these diseases interact with each other and what they can tell about each other. How do they affect each other over time, and how do they change for a particular individual? Is there something unique to a subgroup or a specific individual? So if you allow me a metaphor, I view these learning engines for healthcare as a departure in a similar way as we used to navigate in the past to go from one location to another using paper maps. And we really needed to plan every single bit of it. And if it changed our mind or something has happened, we really need to replan. So everything was very static and very one-size-fits-all. While currently, most of us are navigating with apps such as Waze, which are enabling us to on-the-fly adapt to the different environments we are navigating through. And they are also even able to anticipate our needs. They will know that we want to take a detour to take a cup of coffee, or that we are always starting our journey late. So to make a comparison, the electronic health records provide currently a static, passive, and isolated display of information. What I believe the learning engines for healthcare can do is provide a dynamic, active, holistic, and individualized display of information. Electronic health records are mostly targeting clinicians, but the learning engines for healthcare involve all the stakeholders in the healthcare system, whether they are nurses, whether there are researchers trying to understand disease, whether it's healthcare planners trying to understand how to better plan the resources of a hospital or of a clinic, or whether it's the patient himself trying to get more engaged into their health. So we are trying to move from the one-size-fits-all display of information to an active and individualized and targeted display of information, where the learning engines for health are going to have different views, even though they address and they access the same data and analytics underneath. And electronic health records are currently more like a data storage and presentation platform. Of course, occasionally you would have a risk score embedded into it, but it's again of a one-size-fits-all. While the learning engines for healthcare can provide, in addition to storage and presentation, actionable intelligence and decision support for the patient, the clinician, the nurse, or somebody else involved in the healthcare of this particular patient. And last but not least, it is this interaction between practitioners and researchers that can lead to new insights and adoption of these insights in a fast and integrated way into clinical practice by using this as a resource not only for delivering care, but also understanding disease, and hence changing electronic health records of today into a much more data-driven, actionable, and research-driven ecosystem. But to do that, what are the challenges? Well, let's look first at data. There are multiple data streams that we often have available. And again, these data sets may be collected sometimes at home by the patient wearing a Fitbit, or in outpatient clinics, and at other times in hospital. The data may have different value, may have different amounts of noise, may be collected at very different time frames, at times may be informatively sampled, at times sparsely sampled. We may have information about some of the morbidities the patient has, but not others. There may be quite a lot of information that's unobserved or not diagnosed yet. Also, the onset of certain diseases may be unknown. And there are many possible patterns. We have very heterogeneous phenotypes, and different patients may deteriorate or may progress towards disease in very different ways. Yet what we would like to do is we would like to have a way to understand health trajectories at the individualized level. So what we have is observations like this one. I just show here one particular observation. Maybe it's a blood pressure that's collected with a certain frequency whenever the patient goes to see her clinician. And what we would like to do is to infer from the variety of information that may be collected at home, in the hospital or clinic, and infer on the basis of this vast amount of information the underlying states of the patient. Unfortunately, these underlying states of the patient are unobserved. They may encode different morbidities that the patient was already diagnosed with or not diagnosed with. But in addition to what is already encoded, there may be other factors that are not observed and that play an important role in the disease and health trajectory of a patient. And understanding these current as well as future underlying states of a patient are important. They are important to be able to better diagnose, to better do predictions in the future, in the short-term future, in the long-term future, but also to be able to compare patients, to be able to understand patients like me. Patients like me are not necessarily patients that wear red glasses and have short hair and are women. Patients like me may be patients that look very differently than me, but from a healthcare point of view and from a trajectory point of view are going to be very similar. And identifying that is not such an easy task. To understand that, let's take this particular example where I have two individuals. One is woman and young, and here we have a gentleman which is significantly older. And what you can see if you look at the trajectory of diagnosis of these two patients is that both of them had this particular diagnosis. So both of them have experienced this cardiovascular event, yet they are very different, both in terms of their static information, but also the context in which they have developed this particular disease is different. And unsurprisingly, their future prognosis is going to be very different as well. Yet, they have both experienced the same event. So there are similarities and differences between these patients. And allow me to just briefly paraphrase the father of modern medicine, who said, if we were not for the great variability between individuals, medicine might as well be a science, not an art. And what I hope machine learning can do is to make medicine more of a science than an art. So what we would like to do? We would like to, for instance, use machine learning methods to look at observational data like this one and be able to very rigorously quantify what is the state the patient currently is in. And we would like to do that both at the current time to do more accurate diagnosis, but also we would like to do that for the shorter and longer run prognosis. And last but not least, we would like also to determine when is the right moment to act. When should I give this particular patient, I should start to treat them, for instance, for high cholesterol, or I should give them medication to reduce their blood pressure. When is this ideal time? So again, a small metaphor here. Let's go back to the ancient Greeks who had 2 words for time. A lot of the current research views the trajectories of the patients very much in chronos time, chronological, sequential, linear time. But the reality is that possibly in order to better understand and treat the disease, we should think about kairos time, which is a situational time, a proper and opportune time for action. But to be able to do that, one needs to have tools such as machine learning, such that one can align and think about the current opportune time for this particular patient. So what we need is tools that are general and enable us to look at whatever observational data we have and say something about the patient in the current moment as well as over time. And learn on the basis of the available data that we have about the current patient as well as other patients, as well as clinical knowledge. And in the process, learn longitudinal models of health and disease, which are able to map clinical states into observable data. So given a particular state, what is the type of data that we are likely to see? And then at runtime, to probabilistic inference, where we are going to be able to say, given the data that I observe, what is the likelihood that I'm seeing this patient to be currently in this particular state? And what is the likely trajectory of future states? So what we need is very powerful models that are able to learn from the messy data that we have available, as well as integrate clinical knowledge, such that we can understand the data, model trajectories of disease, learn parameters of such disease trajectories for the individual, and then at runtime, we are able for the patient in front of us to make such projections in an accurate fashion. But how to do that? Very often what's common to almost all of us is thinking in a Markovian world, where the future evolution depends only on the current state of the patient. We see the patient and the patient has experienced myocardial infarction or has experienced colon cancer. And we often forget what has preceded that. But it is clear that while Markov models are wonderful because they are easy to compute and understand, I would argue that they are often simply wrong. History matters. It is the time that a particular disease has taken so far, a particular symptom has occurred. But also the timing of events. For instance, the fact that one particular diagnosis happened before or after another diagnosis. So it's the order of the events that matters at times, as well as the timing of this particular event. When in the sequence of events this particular symptom occurred. And Markov models are not capable to do that. So is our saving into deep learning? Can deep learning save us? We all are hearing so much about it nowadays. And one particular deep learning method that has been very successful in the area of natural language processing is called recurrent neural networks. And recurrent neural networks consider the time and order of events, but they do not have a notion of state. And because of that, they are not interpretable. And importantly, they cannot use or extract clinical knowledge. So they are kind of useless for our purpose. So what we have developed together with my student Ahmed Allah was a framework that we call PASS, which is a general and versatile deep probabilistic model that is able to capture complex, non-stationary interactions of trajectories of disease at the individualized level. And an advantage of this method is that it marries the interpretability of hidden Markov models that are able to provide a natural probabilistic structure that is easy to understand and absorb with the power of deep learning, which is able to learn very powerful, complex representation from complex data. PASS is a generalization of many things, many different types of techniques that have preceded it, both from our group as well as many others. And the idea there is that we are able to model complex dependencies of the history and how do they affect the future states. And the idea is to model these complex dynamics of history using the idea of attention, where depending on how important a particular past state has been and how is that changing over time, it will influence the dynamics and the transition to future states. Let me, for that, with a little bit of a abuse of notation for the ones among you that may be mathematicians or machine learners, I'm unraveling here a graphical model to really kind of portray what we are doing. So what we are learning is something that we call contextual attention. So what we do is we learn attention weights, but unlike in the area of deep learning, where attentions are put on observations and then nobody knows anymore what is happening, in our case, we are putting attention on states. So we are learning in this way how much each particular state is not or is affected by past states. And you can think about the width of these weights as being the attention. How much should I care about past events, and how much possibly I should care about observations? And how do they inform the transitions at the current moment in time or in the future? PASS is able to repeatedly update these attention weights to focus on past state realizations to better predict the future. And also the memory is shaped by the patient's current context, which may include the static information about the patient, the sequence of events so far, and possibly the treatment which the patient has undergone. We are also in this way able to do individualization and individualized dynamics and trajectories of disease in a natural way. So we have two patients here again, and we are able to contextualize the trajectory and make projections about the disease of these two patients, as well as understand why something has happened, and do that in an individualized way, not only by looking at the static information of the patient, current information about their age, gender, genetic information, but also by looking at the dynamic context of the patient. What type of pollution they have been exposed to, what type of radiation they have been exposed to, what type of environmental factors may have mattered. So again, to be able to do that, we would like to be able to do inference in real time. We would like to be able to say, this is what I have observed, what is the current state of the patient for diagnosis as well as prognosis. And doing so, it's complicated because the data that we have doesn't reveal everything. So we have many states that the patient may have passed through, maybe some preclinical states where there were not observations, or we don't have high-quality observations. And the challenge here is that not only the states, but also the times are hidden. We don't know how long the patient has been in a particular state. There may be transitions between states, possibly back and forth, without observations. The patient didn't even show up to the doctor. There may be stage transitions that depend on the entire history of disease. And the observation samples may be noisy and possibly irregularly spaced. So it is very complicated to do that in practice. And last but not least, it is complicated to come up with beautiful analytical representations that enable us to compute these probabilities of the patient being within a particular state. So the way we do it is we are using actually a deep learning model to be able to allow us to infer and to learn on the basis of this vast, complex data, these posterior distributions. The fact that a particular patient, for instance, Anne, finds herself at this moment in time in this particular state, given the past observations we have about Anne, her static information, as well as the time of the past observations. So we are going to try to learn all of that using a deep learning model. And what we have in the end, this is how we marry both worlds. We are able to, on one hand, learn complex representations of these posterior distributions while learning interpretable attentive state spaces, which tell us exactly what should we pay attention from in the past. And we are doing that by optimizing these two networks in joint fashion. So if we do all that, we are able now to learn on the basis of the data and make inferences for the patient at hand. And while doing so, we can have more refined and more precise diagnosis, because now the entire history of the patient may matter. So staging of disease may be better, and grading of disease, but also asking questions about onset may be better, maybe more improved and refined. And prognosis also by looking at the history of the patient, inclusively their adherence to medication or their diet or their own private support system may influence the prognosis of this particular patient. And unlike the past setting where we use methods such as Hoch's proportional hazard models to do survival analysis, time to event analysis, where we often regress a single static and population level time to event hazard curve. Now we have with PASS the ability to do ongoing, dynamic, and personalized time to event analysis, where as observations are gathered over time, we can personalize this analysis. And also looking at not only at one disease, but at a variety of diseases together and how do they affect each other, thereby being able to understand competing risks is done in a natural way as well. So let me illustrate this with an example from cystic fibrosis, which is an area that I work on quite a lot because of my collaboration with the Cystic Fibrosis Trust at the Alan Turing Institute. So CF is a complicated disease, and is a disease that is a useful example to illustrate the power of this technology, partially because it's a very heterogeneous disease. Patients are often young, and they deteriorate in various different ways. So practice and medications are also evolving over time. So there is a lot of need for decision support. And there are many therapeutic options. And at times, patients get a lot, possibly too many, different types of medications and interventions. So it's important to understand how to better support both the clinician, but also the family and the patient. So we really need decision support systems to really support everybody involved in the healthcare of the patient. But we also need methods such as learning engines for healthcare to understand better this complicated disease and why there is so much heterogeneity in deterioration. So to do that, we have applied these learning engines for health to the cystic fibrosis data set of UK. And what we have learned on the basis of it is a refined staging of the disease, improved diagnosis about the patient being in a particular stage, improved phenotypes, predictions of risk of mortality, for instance, or lung deterioration, onset of disease, but also we can say what type of information was collected at these different visits and how does this past information has contributed to projections into the future. Was it really needed to collect this information? What is the value of it for the current patient? And in the future, should we collect a different information to better inform us about the trajectory of this particular patient? Just to show a brief illustration, what you see here is the key biomarker for cystic fibrosis, which is the forced expiratory volume. And what you can see is here the distribution of FEV1 at the different stages of disease. And you can see that as the patient is starting to deteriorate, the FEV is starting to shift to the left, to a lower forced expiratory volume. The patient is degrading, and their ability, their lungs are degrading. Also, what you see is the distribution of clinical events. And you see that this is changing as well, and they are accumulating more and more morbidities and comorbidities. And what's also interesting is how important are the past visits. We plotted actually a lot of dependencies. I'm just showing you here one, which I thought was kind of interesting, that initially when the patient is doing quite well, it is mainly the current information that matters. But as the disease is progressing, past information and the trajectory of the patient starts to be increasingly more informative. So can we use that not only to understand what is happening, but also make projections for the patient at hand? Can we project on the basis of past information for this particular individual how different biomarkers would look like, what are the risks for different comorbidities, or do time-to-event analysis? And what I'm showing to you here is a comparison between PASS and one particular methodology from statistics, which was often used in settings like this, which is joint models. And what you can see here is a variety of results. First, you see a mean square error, so the lower the better, in which we are predicting the key biomarker. And you can see that PASS is doing really significantly better at predicting this biomarker. Then what you see is for both a variety of comorbidities and infections, you see the area under receiver operating curve, so metric of performance, and the precision recall curves, the sensitivity versus precision. And you see that the performance we get is significantly better than the statistical methods that are currently used in practice. But we can do even more than just predictions. We are able to learn about the value of information for this particular individual. We are able to say, well, given the information that I have now and the lab tests I'm doing today, what I expect, how I expect this patient to evolve over time, and when should this patient come next? In a month, in 5 years, never? And at the time they are coming, what do I expect to see? What type of diseases I would need to monitor for? Also, in this way, we are able to learn causal associations and relationships between morbidities. And it's important to realize that we are going way beyond what people have done in the past, where they have just drawn comorbidity maps like that, where they said this disease relates to that disease and this is how it relates. No, now we are able to do dynamic analysis of such relationships. We are learning that not always these particular relationships hold, but for different types of patients, it may be that different relationships appear, and the time at which the relationship appears matters as well. Did this disease happen first and this second, or vice versa? And depending on the order of this network and this relationship, what do we learn about the disease and the expression of this disease in different types of patients? Also, we are moving from a population level comorbidity and morbidity map, not only to a dynamic one, but also to a personalized one, where the order of the different events matters, and that tells something about the particular phenotype that the patient is in. But most importantly, probably, is the need to understand how to treat. How shall we treat this particular patient, and when shall we treat him or her? And we would like to do that in an individualized way. So ideally, we would like to move to an era of individualized medicine. And I do not mean by that genomic-informed medicine. I mean, even for the case where we do not know any information about this patient, particular genetic characteristic. I just know some information that may be available in the electronic health record of a patient. How do I decide whether, upon a particular CVD diagnosis, I should give a particular medication to one patient possibly and not another? How to do that in a setting in which clinical trials are often small sample size? They do not include the elderly and the ones that have multiple morbidities, or the unrepresentative young. In such settings, we would like to go beyond just electronic health record data, to go beyond, just clinical trials. We would like, after a clinical trial has been conducted and the medication is given to the patient, to learn from electronic health record data heterogeneous treatment effects. And we would like to be able to learn for this particular patient what type of treatment to give. And we would like, for instance, for the example before, to know what type of medication we should recommend, or the lack of medication to a particular patient. And this is a hard problem. This is probably one of the hardest problems in machine learning. And the reason it's hard is, on one hand, we do not have counterfactuals. We do not know what would have happened to Kathy, for instance, if we gave or didn't give a particular medication. We just have the factuals. Another key problem is that the data is biased. It's biased by the clinician in front of the patient making a value judgment on whether they should or shouldn't treat a particular patient. So this is a complicated problem. And what we would like to do is we would like to estimate individualized treatment outcomes. We would like to look at a particular patient feature. Here is, I'm just plotting in one dimension, but you can think about many features that are characterizing the current patient. And you would like to look at the current patient and say, what would have happened if I would have treated this patient? So what we would like to do, in effect, is to look at the characteristics of the patient and identify the individualized treatment effects. So what we would like to do is we would like to look at the available biased data to estimate a model for that outcome. And the difference between the outcomes is the treatment effect, and the difference of the models estimating these outcomes is the estimated treatment effect. And again, this is complicated. It's not a standard machine learning problem. It's a lot more complicated because of the fact that we cannot just do some type of simple minimization of risk or maximization of outcome. We do not have labels. We do not have counterfactuals, and there is bias. So important questions in this setting are, how do we really encode treatment? And how do we really deal with this selection bias? And past approaches to this have really been quite ad hoc. They didn't have good measures of uncertainty. They were not providing understandings of what is possible in a particular data set that may have a particular bias and only a small number of samples. So what we have tried to do is we have tried to come up with a lot more rigorous an approach to this problem to try to understand how flexible our models should be to deal with model misspecification, how to provide uncertainty associated with certain predictions such that the clinician knows, is this something that we are very sure about? Is this type of prediction of this particular treatment being very good for the patient at hand accurate or not? And also understand, in an information theoretic sense, what can be achievable given the data that we have, such that we know what type of data we should request in the future if we want to be able to do such analysis. And we have worked quite a lot of that in the past 1 year and a half. And among many other things, we learned to use much more effectively the available data and learn in a shared way, learning shared representations across the treated and untreated population. And develop for that theory as well as informed by theory practical machine learning methods. And we are in recent times applying it to real-world data to be able to estimate the effect of treatments and estimate counterfactuals. I'm not going to bother you with too much detail, but let me just say these are the results that we are obtaining using our own method. And what I'm presenting here is, again, an error in estimating treatment effects, so the lower the better. And this is what's called the precision in estimating heterogeneous effects. So this is how well we could have computed counterfactuals. And you see that we are doing quite a lot better. And it is with the hope that these techniques really cannot replace but augment clinical trials. Doing post hoc analysis of clinical trials to identify on the basis of it which patients will most benefit, use observational data after a drug has been approved to understand who will most benefit, but also use that information to inform and target to a particular subpopulation future drugs, thereby conducting much more effective clinical trials, and also serve as a recommender system for the clinician, understanding what are the different options for a particular patient. So really we are on a journey by developing this type of machine learning methods, artificial intelligence, as well as operation research to hopefully better understand and treat disease. And it is really not, like Dr. Un has said, our goal to really replace clinicians. Our role is I see it as augmenting clinicians and empowering them. Empowering them by providing them high-quality actionable intelligence such that they can, with almost the microscope of machine learning, look at the patient in front of them and understand the complexity of the current patient. Empowering patients such that they become more involved with these tools in their own healthcare, whether take their medication or exercise more. Empower healthcare planners to think more effectively about the available resources and how they should be targeted for the patients that need them most. But also empower educators and researchers to use these available resources to better understand disease. And also, not only a move from this current approach of generating hypotheses into a more quantitative data-induced hypothesis generation scenario. And let me just briefly say that it is with the healthcare workforce in mind that I am part of the Topol Review, which is a national review in the UK, led by Eric Topol, for which I'm co-chairing the AI and robotics section. And what we are looking in this setting is exactly how these technologies can empower the workforce. And what will the future workforce need to know in the healthcare domain to be able to harness the sheer power of this technology, not with the goal of replacing, but rather empowering the future generation. So this brings me to my final slide. I view machine learning as an important tool, a multi-purpose tool, which can, on one hand, really provide actionable intelligence for empowering clinicians, using electronic health records in a much more powerful way, generating for clinical researchers data-induced hypotheses, while clinical practice is improving at the same time, integrating this together with omics data and understand what is the value and the value of information for different people which may or may not have certain genetic mutations, and also using all this knowledge and all this information to develop better pharmaceuticals and better therapies and understand how to personalize treatment. Thank you so much.
Well, thank you very much for a fascinating session on that. I think we have some time for some questions, if you want to take some. So, are there any questions for? Yes.
Thank you very much for that. I was just wondering, do you think that this is what patients Do you think this is what patients themselves actually want? Sort of considering that we have a very aging population and that doctors are progressively treating older and older people. Is this something that sort of an elderly population can interact with, and it's often the elderly population that most value sort of the clinical skills of a doctor and sort of all of the communication skills that come with it. Do you think that they actually want to rely on this system of technology instead of sort of doctors' clinical acumen?
So thank you so much for the question. So multiple questions in your question, I think. So one of them is, would I like my doctor, even if I'm 80 years old, to fly a plane just by his own skill? Or would I like to empower the doctor to have high technology available to him such that in the very limited time that he or she needs to see me, which is often just 15 minutes, the entire information about me, which is a long time because I'm 80 now, is presented to my doctor such that he is empowered to make the right decision for me. Again, what I'm talking here is not replacing the doctor. The value judgment will still be made by my doctor. But I would like this doctor to have an integrated view of my disease and have cutting-edge technology to better diagnose me, especially in an era where there is very limited time with our clinicians. Do I believe that patients are evolving more and more with these technologies? Yes, I do believe that. It is surprising how often, for instance, my own father, who is a clinician and not at all very savvy, let's say, technologist, has embraced technologies like a cell phone. These applications are becoming simpler and simpler. And it is surprising that we are able to order shoes in Amazon and movies on Netflix. Why shouldn't we, with the emergence of better and better apps, be able to get more involved to manage our intake of medication such that we can adhere to medication that is prescribed to us, or maybe exercise a little more, or drink a little bit less coffee?
Thanks for a great talk. So following up a bit on the report that you just mentioned, could you comment on what the physician of the future will have to know? Will they have to know deep learning? Will they have to take courses on machine learning during their undergrad?
So let me just say that in an earlier conversation this afternoon, I discovered that some of the people in the audience are already having this mixed background. So there will be a minority of people who may have undergraduates in engineering and may pursue afterwards a medical education. And it seems that increasingly this is happening. But by no means I see that. What I see is, you can think about, let me make an analogy with architecture. Increasingly, architects are using technology such as AutoCAD, or they are using technologies in general to envision how a building may look like and to play with it. They do not need to understand the underlying backbones of the software, which is rapidly advancing. In a similar way, by no means I see the clinicians needing to learn deep learning. Deep learning may not exist in 2 years' time, and we may have deep learning or pervasive learning or who knows what. What I think is much more important is for clinicians and doctors, as well as researchers in the clinical fields, to engage with what these techniques can do. Because right now we are in a very unfortunate setting. We are in a setting where different companies that are technology companies are pushing technology onto clinicians and onto patients because of their own benefit. Not necessarily because these technologies are useful for the patient or for the doctor. So what I would like to ask all the clinicians and the medical researchers in the audience is to embrace these technologies, to take a look at them, not to be scared by them because they are often underneath, and understand how this technology can be used to empower them. And they should be the ones that should kind of develop the requirements, if you like, of what is useful. So what I do believe is that future clinicians and medical researchers will not know deep learning, but they will be familiar with what is possible and will demand from people like me the development of technology that is truly useful. And in a similar way as an architect is the one that's envisioning the ecosystem of a building, similarly, the electronic health record of the future shouldn't be provided to you by some technology company, but rather it may look very different for one person that may have a particular specialty and may see one type of patients versus somebody else which may be having more time for research and may see patients of a different kind.
Thank you.
So thank you very much. You stressed the importance of historical factors rather than the current state. And of course, there is very much a Bayesian type of approach. But I wondered if you took the ultimate prize here, likely to be genomic. And so to what extent do you think the future genomic information we're going to have about everyone will complicate or simplify the task of machine learning in these very complex polygenic disorders?
So many questions there also. So first, I didn't say that the current information doesn't matter. I think the current information does matter. All I'm saying is that past information may matter, and which past information and for whom may be different. So an important pursuit for me, even though I'm a machine learning person who loves data, is to understand what data is valuable, when, and for whom. So it may be that certain diseases or certain patients may be very much dominated by the genetic material of that person, while some others may be less so. And in those cases, we would like to understand, again, what's the value of acquiring this new piece of information for the sake of either understanding disease in a population or in a subgroup, and possibly even more importantly for this particular patient's future trajectory. What information should I collect such that when I need to make in the future a particular diagnosis, I'm going to be more informed. So I think that there is not one or another. I feel like they are going to complement each other. And I also feel that the area of machine learning in general can help with the complicated field of genomics as well. And there is a lot of excitement, I think, there as well. My own research so far has not been focused on that, but I really hope that this will change very soon, now that I'm in Cambridge.
So maybe a follow-on from that, as sort of quite a practical question. So you gave the nice example with cystic fibrosis, which is obviously a heterogeneous disease, but well diagnosed and a strong patient population, and reference to what you just described. Practically, what disease and what types of data set would be most valuable beyond the kind of cystic fibrosis setting that could validate the models? And
so one data set that I'm extremely interested in, so there are two types of settings so this has to do not so much with the methods. I think the methods can be generally applicable, but there are two types of settings that I'm very interested in. One of them is the general practice data, because that's the moment when there is a lot of scarce data that may be available, yet that's the GP in the end that is the one that is going to possibly see certain symptoms developing, possibly diagnose the onset of a particular disease. So it is data from general practitioners that interest me very much. There is also another type of data that I've been working much more with and that I'm much more familiar with, and that's the data of hospitalized patients who may be hospitalized for different reasons or the same reason, but their trajectories and their journey through the hospital stay, it's really quite different. So that's another setting where it is extremely important to understand what information to acquire, when to decide that this person is safe to go home, when do you need to rush this patient to a particular surgery. And that can be very important, both because it's such an important time in the lifetime of a patient, the patient already is hospitalized, but also because the available resources are so scarce. And it is extremely important to do correct understanding of where the patient is at and what resources, clinical resources, this person may need in the short run and in the long run, such that we more effectively plan and utilize these resources. But I view these techniques as possibly in other areas as well. And what I think is very interesting is to understand relationships between diseases and really try to understand how the onset of one may trigger the onset of another. And how do this, is this a one-size-fits-all? Are different patients exhibiting these different morbidities or comorbidities at different time spans, in different orders? Clearly, that's the case for cystic fibrosis. Is it true for many other diseases? So I think I view this more as a tool for understanding, and I hope to have clinical partners that are interested to engage with me to look at these problems. Because, as I was mentioning before, I don't feel that the technologies should do more than advertise their tools and then invite, hopefully, others to look through this microscope.
Thank you for your talk. What are the data storage considerations with LEH and PASS, and do you envision this being an issue when implementing it on in an NHS setting?
So first, it is important to realize that learning happens offline. So both the data that's required, as well, both the storage as well as the computational facility could be quite involved at times, depending on the volume of data you would like to allow these methods to learn from. But that is done offline. At runtime, at operationalization time, where this could be embedded in the dashboard of a clinician, or it could be on a cell phone of a clinician or of a patient, we already have learned that particular model. And we may only once in a while issue updates. So at runtime, these models are already trained, they're already learned. So it is just issuing inferences at runtime. So we are on purpose creating algorithms that are, if you like, asymmetric, are complex at offline when we are learning the model, but are quite simple and easy to use and only need a very limited amount of information and computational power at runtime. But this brings another issue, which I'm not sure you are asking, but I'm jumping at the opportunity to talk about because I'm doing quite a lot of research in this area. I'm very interested in it. How can you take something that was developed, for instance, in London, and you can move it to Singapore and be sure that the same type of method will still work. So this is, I think, very important. You would like to understand the robustness of these techniques and the transferability of these techniques. So a lot of my research currently is looking at that, trying to understand what type of guarantees can you give. If you are taking one particular system and you move it to another environment where the population may be biased, may drink less, may exercise more, may smoke more, and possibly, even more interestingly, the data that is acquired may be different because clinical practice is different in these different places. Again, machine learning can do, I believe, quite a lot in this area as well. But again, we need to involve ourselves with clinicians and practitioners and healthcare planners in these different ecosystems to understand what we can learn and what we can learn together. And I think that that's important because just to mention cystic fibrosis, which is a disease that I'm so interested in, you don't have huge amounts of patients. You need to pull resources together from different places and different countries because otherwise you're not going to have just your particular hospital enough cases. So I think this type of mindset where we are learning together while being mindful of differences in the patients and in the practice is important.
Thank you.
Thank you. Any other questions?
Hi, thanks for a great talk. So one quick question I had is, you mentioned you really want to get hold of GP data, and something we were actually discussing today is that GPs use different systems. Some of them codify, some of them don't. And we're having that problem with trying to interpret in a basic clinical trial. Do you think your machine learning, when it's already having to cope with sporadic data, can also cope with the fact that the codification and the recording of that data can be incredibly different depending what location it's being recorded at?
Thank you for a very interesting question. I've not thought about that ever before. But I think that, yes, there may be a hope, not for complete automatization, but let's take a simpler example, but also complicated. Machine learning is extremely successful in translation, translating across languages. Now, I understand that what you are talking about is complex at a different level. But I think that there is an opportunity that I think that machine learning is good at doing dumb tasks that are somewhat repetitive and there is quite a lot of structure. So I think that this is an example where as long as there is some knowledge and there is some standard with which data was collected, going across these different, let's say, various data sources to homogenize them and to bring them into a common format and to a common language, I think, yes, that should be a relatively easy task to do if one is okay with dirtying their hands and understanding all the data that is involved to do that, and does that carefully and accurately, which not everybody is willing to do.
Thank you. Is there another question behind you?
Of data, prioritization of resources allocation. A patient who is highlighted will be given more resources than the patient who is not.
So thank you for this question. So again, many, many different thoughts there. So first, the answer is yes and no, in my opinion. So first, one of the things that I was very scared as a patient, and I'm always scared, is if I get sick, how do I make sure that I see the best possible doctor I can? And maybe because my father is a clinician, I'll have access to that. These methods are able to much more create a standard, a minimum of care, such that independently of, hopefully, who is the person you are seeing, who your GP is, all the boats are lifted because we are able to learn from the judgment and the value judgments of the clinicians and from different types of sources of data to be able to elevate the level of knowledge, such that it's no longer just an art. And my father, who believes in art as a medicine as art, will say, well, there will always be a very big difference between clinicians. Granted, it will be. But what this will do, hopefully, it will bring that particular level of quality of care at another level by prompting clinicians about mistakes they may make. So that's number one. So I think that on one hand, inequalities will be reduced and you will be less as a patient vulnerable that you don't know about the quality of the clinician you are going to see. Number two, yes, Mr. Jones may not show up so often to the doctor, but hopefully because other people did, there may be an opportunity to learn even about the current, given the current information of Mr. Jones. You are right that in our system, if the person never showed up and we know very little about them, it is only the current information that's available and we will need to reason only on the basis of that. But the fact that we know about many other Mr. Jones and we will have at least an idea about what different types of paths this Mr. Jones could take, given the possible pasts that this particular person has. And last but not least, I feel that while it's true that going to the doctor is going to be clearly a privilege of the few, some of the other technology, whether it's embedded in our phone or it's becoming extremely cheap and commoditized. So while a visit to the doctor may still be a luxury, a lot of the other, let's say, devices that may integrate this information may become increasingly cheaper and cheaper. From doing an ultrasound on a cell phone at times, people are increasingly building such apps, to getting genomic and genetic information and genetic testing at a much lower cost. So I do think that a lot of these technologies are commoditized, and in the process, a lot more information becomes available. So I'm optimistic about all this. What I'm not so optimistic about, and I think you kind of touch on that as well, is the fact that the data, if it's garbage in, garbage out. So if the data we have at our availability is very poor, very low quality, what I think it is a challenge for us as the community of machine learning mathematicians, statisticians, to think about this problem and try to understand how really can we deal with data quality, when can we realize that the data is just not good enough and we should deal with it in a different way. So I think that that's more of a challenge to my community, that we need to take home and make inferences while being aware that the data that we may have at hand may be of very poor quality.
Thank you. Last question.
Thank you very much for your talk. I'm very interested to see that you want to share things back with the patient, which is fantastic, and their family. But I wonder where you draw the line with that, because if people have too much access to this information, they may start to make decisions to go to the doctor more or less. You know, if they start to see, you know, survival curve information or the kind of stuff you were showing earlier, they probably may not understand it completely, and then they may go to the doctor more, or they may stop going to the doctor based on what they're seeing. Then this may start introducing some kind of feed-forward loop, you know?
So I think that there is not a sweet spot for a particular patient, for a particular clinician, or for a particular disease. There may be multiple optimal points, and this is why I'm inviting the community of clinicians especially, and clinical researchers, to get engaged to these tools. These tools are already out there in some shape or form. Maybe not the shape that I showed you here, which is quite sophisticated, but already there are a lot of apps out there in the wild world which are at times used by the patients. So what I'm trying to do with this is kind of a call to action for the clinical community to engage with these tools, such that these tools are created in a way that the clinicians find valuable for their patients, and they find a sweet spot in managing their patients, old or young, very sick or not very sick, technology savvy or not, poor or not poor, such that they get engaged. It may be, for instance, going to the previous question, that patients that may be very poor, they don't have the time to go to the doctor, but they may have the time to maybe do a quick call with an app that is a proxy of their GP. Or you may find different patterns of interaction with different types of patients. So again, it's a call to arms for clinicians to kind of design and co-design this type of future together with people like me.
Thank you. I'm just going to ask one final question for myself, which is you've highlighted a really interesting transition from electronic health records to learning engines for health. And there's a number of challenges. Some of the questions have alluded to this in cultural changes, regulatory possible changes, technical developments. Which do you think is going to be the biggest hurdle to that in the next few years to moving towards the model you've described?
A complicated question. So I think a lot of this is a lot shorter term than one thinks if one is eager to embrace this type of technology. What I often hear when I discuss with different types of clinicians, both in United States as well as here in UK, I find often frustration because currently these electronic health records are just a data entry and maybe a history you can see. But if we can turn relatively fast space by co-designing these new health records of the future, I think that they can be a lot more valuable because your electronic version, your learning engine may look differently than that of another clinician. And the needs of what you would like to see, given both your own specialty, the type of patients you are seeing, and the ecosystem you are in, may be very different. So I feel that relatively easy, the technology is up there to kind of personalize this to a particular clinician and turn it into a valuable tool. And if the clinician is finding only a particular feature useful, that may be by itself enough.
Okay, thank you. So with that, I'll hand back over to the master who's got a presentation.
Thank you.
Well, thank you, Mihaela. Thank you very much for an excellent and impassioned talk. I think we could really feel the sense of excitement and the potential you feel for machine learning. And I think the engagement of the questions really demonstrates that. So thank you. To conclude, I would like to ask Professor Gabriel Oon to come on stage and to make the presentation to Mihaela.
Thank you very much.
Congratulations.
Thank you very much. Thank you. Thank you. Thank you very much. Thank you. Thank you very, very much. Thank you. Thank you very much. And thank you all for making time. I see many faces of people that I know are extremely busy, so I much thank you all for coming here today. Thank you.